It's okay? The network is very, very unstable. Oh, disappear. Okay, shall we start? This is Japanese registration data, but it just started from 2013. No, around 2010. But the data is not perfect. Maybe around 20 or 30% have joined this registration. Most of data is missed. This is quite different from the registration data in the Europe and America and Australia and New Zealand. But just started. But it is a very valuable data for both Japan and maybe other Asian countries. Because the situation of the patient is quite different from the European countries and the Asian countries. So maybe you can learn a lot about our data. Okay. This is the number of registrations. So both total hip and total knee is just below approximately 18,000. My baby, this is the 1/5. In the country in Japan, the total knee is performed around 100,000 annually. It is not perfect, but we can see some tendency or trend using this our data. So next, this is the hospital is joining this registration. On the 2017, only 122, the totally 1,000. It's a very small number, or not perfect. So, but increasing by time. So, this is the number of the total hip and the total knee. Maybe total knee is 1.5 times higher than the THA, but virtually same in the registration. But in the newest data show that the TK is more number, have the more number of the operation than the total hip. This is a distribution of primary total hip. Maybe this data shows that maybe our country's patient is older than your country, maybe. In your country, the average age should be 40s or even 30s. I previously heard about this. Maybe due to the osteonecrosis of the femoral head. But unlike a country, our country is primary cause of total hip is dysplasia. So in the younger age, the patient with dysplasia is no symptom. They can run, they can play in sports. But after the 40s and the 50s, gradually they will get the pain, dysfunction of their hips. Then eventually he go to the clinic and they find that they have dysplasia. This is the main cause. Unlike the dislocation, the only dysplasia is no symptom. Nobody knows, including themselves and their parents, their friends. It is hard to recognize the patient has dysplasia in the younger age. This is the primary diagnosis of the total hip. Previously, DDH, developmental dysplasia of hip, is around two-thirds of the patients undergoing total hip arthroplasty. How about your country? Maybe the primary cause should be the IOL, idiopathic osteonecrosis, right? Maybe. But even in Japan, dysplasia getting smaller, decreasing by time because of prevention of the dislocation or dysplasia and early diagnosis of dysplasia and change of the custom. The previously in Japan, the diaper was on the rolling diaper. The child or baby have to extend their hips, but maybe the 1960s or 1970s, the custom is dramatically changed to the open the hip, abduct the hip, then takes the diaper. This is a custom. In the friction, the hip develops very well. But if the patient extends the hip due to the tension of the iliopsoas or other muscles, the hip tend to subluxation and eventually dysplasia or even dislocation. So previously, this name was congenital dislocation of hip. But now we know some patients have the congenital dislocation, but they had dysplasia or congenital dislocation. But in fact, even the child have the normal hip at their birth, after the bad custom, like the rolling diaper, they that make the dysplasia or dislocation in after the birth. So we change the name from the congenital to the developmental. It includes the congenital or early baby period due to the bad custom. So, but thanks to the information how to treat the patient baby's hip, then gradually we change the custom, and then in the same time, main child underwent the hip check in their baby period. So then the number is decreasing gradually. But even the recent data is around half patient had a DDH. But in contrast, DDH is decreasing, but in contrast, the primary OA is increasing. Well, how about your country? So many DDH dysplasia patients in the childhood? Oh, I can hear you.
Mostly we found the primary OA and mostly osteonecrosis, I think.
I know.
Deviations are too little.
Okay. But I find that
Yeah.
you have so many crab foot
Yeah.
in the
Yeah.
display, the deformity of the foot. It is quite different in Japan. Japan is virtually no patient. It is quite rare in Japan. But even if,
Yeah.
but
Yeah.
even now, there are so many dysplasia patients, and necrosis is very
Yeah.
rare. Maybe
Yeah.
necrosis is more frequent in knee rather than hip. It's very interesting. Okay.
In mainly, I
Yeah.
mostly found the osteonecrosis patient. We do the hip arthroplasty.
I know. I
Uh,
know.
yeah, Mostly in osteoarthritis in to the knee arthroplasty.
Yeah.
So I think osteonecrosis and osteoarthritis is more than developmental dysplasia or hip in my
Oh,
country.
okay.
Right? It's not depend. It's not uh, the reality. I find this only osteonecrosis and osteoarthritis is more than the DDH.
Okay. Okay. If you have a chance to come to Japan again, you can see so many
Yes, yes,
patients with the DDH.
yeah,
And even in a child, we sometimes check the pelvic hip. We find so
yeah,
many patients of the dislocation or dysplasia so far.
yes,
Okay, it's interesting. Okay, this is a revision of the total hip, the initial diagnosis. There is no special tendency, but interestingly, trauma is more prevalent, more frequent than the primary one. The trauma is very rare. This primary trauma includes the femoral neck fracture in the younger
yes,
age. But
yeah,
interestingly, trauma is the second
yeah,
the frequent cause of the revision. So maybe it includes the failed bipolar, maybe. Or maybe this is the one reason in Japan, uh, bipolar is for the operation for the resident, less skilled surgeon. Maybe I think it is the one cause of the so frequent total hip after trauma. Okay, so the approach is interesting. The previously and around half, maybe in the 2010 or 2000, this one two-third was the posterior approach.
oh,
But now the anterior approach is increasing and increasing. But the
yeah.
posterior approach is stable, around 40%. The most,
But
the most, yes, please.
I think your posterior approach is very strong now. First, and you only cut two rotator only, and then you
Yeah,
split to see the katsu. So I
yeah,
think after a re-katsu suture, it's
yeah,
maybe more stable than any
yeah,
other
yeah,
approach. So I
yes,
found during my stay in your hospital.
yeah. Maybe posterior approach is quite easy. So now
Yeah.
posterior approach is improving. To retain the piriformis and some
Yes.
rotator muscles, cuts only
Yeah.
the lower one. Okay, but so now, the previously, the one is a posterior approach, and another is a lateral approach, so-called Harding or Dole or something like this. This is a major,
Yeah.
and the posterior and lateral major. direct anterior approach or or anterolateral approach. In a
Yeah.
hospital, Dr. Fujishiro prefer to use anterolateral approach. This approach is included in the anterior approach in this classification. Because the benefit is we can operate uh, the patient in the supine position.
Yes.
It is quite beneficial to the approach, the alignment of the acetabular.
Yeah.
But a little bit difficult to manage
Yeah.
femoral side. In contrast, the posterior approach is quite easy to manage, operate to the femur side, but a little bit difficult. So it can cause sometimes malalignment for the acetabulum. So maybe this is a trend. This is a trend. So as I said before, so posterior approach is improving just now. So it is very interesting. Also, three-fourths patient surgeon selects the cementless. So cemented is very, very limited use. Maybe this is the same trend in your country.
What you mean hybrid?
Hybrid is the female side is cementless and
Oh yes, I see. Okay.
acetabulum side is cemented or vice versa.
Yeah. Yes. Yes.
Uh,
Mostly we use cemented in the femoral side and
or
to
maybe
the acetabular
some
side is
surgeon,
cement.
yes, some surgeon believe that
Yeah.
cement is better than the cementless.
Yes. So, yes.
Okay, so navigation is not popular, but in the last 5 years, so from 2015, navigation is a little bit increasing. This is because of the portable navigation, introduction of the portable navigation. The full navigation system is very expensive, so it is quite
Yes.
difficult to install. So, but with a total portable navigation system, we can easy to pay to the each operation.
Yes.
It is
Luckily,
equivalent to
yes.
the additional cost paid by the
Yes.
insurance system. We can cover the
Yes.
cost for the navigation and from
Yes.
insurance system. So, okay, this is one reason is the gradual increasing of the navigation. So this is the MYS approach. MIS means so one me should be the smaller incision. Maybe the less than 8 centimeter is defined as the MIS approach. In other meaning, it's not only the length of the skin incision, but also the muscle retain. For
Yeah.
example, most anterior approach, such as direct anterior approach or anterior lateral approach, we never cut the muscle, only the separate, divide the muscle.
Split.
Yeah,
Yeah.
maybe this is the benefit. Even lateral
Yeah.
approach, okay, something, Jomiso, okay. Even the lateral approach, we need to detach the part of versus medialis. And the posterior approach, as I said before, so of course we have to cut some part of external rotators. So the one reason should be the supine. We can operate the patient in supine, and another reason should be the muscle retain. So that this policy is included of the medium invasive surgery. Okay, so this is a bone graft. Bone grafting is gradually getting smaller, decreasing. Maybe due to some good stabilizing system of the acetabulum.
even the big bone defect or the lateral edge of the acetabulum, but we can remove the acetabulum and make the good bed for to see the acetabulum cut. So in fact, but I have no experience to use the bone grafting, only the bone grafting of the chip, the space between the acetabulum component and pelvis, just feel the chip of bone. So in the past, around 20 years ago, I sometimes the graft the femur head to the acetabulum edge and make the good bed or see the acetabulum component. But now we never use the bone graft, a very, very limited case, even the patient with the DDH. Due to some technique, and maybe 3D CT is very, very difficult to plan, to implant the acetabulum component. So maybe so using a 3D CT, we can precisely do the plan to where to rim, where to sit the acetabulum component. So the importance of bone grafting is gradually getting down. Okay, this is the antibiotic eroded cement. Is I haven't used the antibiotic cement, but some surgeons prefer to use this. But the percentage is getting smaller. So this is a cause of revision of a total hip. The most frequent cause is the loosening for the acetabulum. The second one is loosening of the femur. The third one is infection. Do you know what is the most frequent cause for the revision for after the total hip in your country?
Mostly I think infection.
Infection.
Yes.
Infection.
We mostly see in revision case mostly infection.
Infection. Okay.
Also, infection can cause the accepted loosening both sides.
Okay. 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 How about the wear, polyethylene wear, and osteolysis?
Yeah, maybe.
Maybe.
Maybe combined, but mostly.
But previously, the polyethylene wear is very frequent because of the bad, insufficient quality of the polyethylene.
Yeah.
But now we can get the very, very improved polyethylene. Or maybe I told before, for example, vitamin E blended by polyethylene or high wings polyethylene. So due to prevent the polyethylene wear, we tended to use the thick polyethylene. I was educated the polyethylene should be at least 1 centimeter. Otherwise, after the wear of the polyethylene, the metal head can hit the get a friction with the acetabulum metal, acetal component metal. But in fact, there is no wear in the modern polyethylene. In the same time, most of osteolysis caused by polyethylene wear, small particle of the polyethylene. So the prevalence of the occurrence of the osteolysis is decreasing and decreasing. And another one is breakage. For example, the acetabulum, I don't know, I haven't experienced the breakage of the acetabulum, but I have two cases. Or maybe this breakage it included some. I experienced detaching the wire in the old polyacetabular component. This is not a revision, but only the removal of the wire, the wire for the mark or the old polyethylene acetabulum. And the breakage, I experienced two cases of the breakage and fracture of the stem neck, femoral component neck. It's very thin. So you should take care. You should carefully look and read the document for the implant. Sometimes it shows clearly the weight limit. And this, in my case, I haven't read the document for the implant, but the document says this is the limit under the 60 kilogram, the patient. The patient was over 80 kilogram. So that's why the neck or the femoral component is broken. So I recommend you to read carefully the document. And the fracture, maybe this is caused by the fall, some falling down from the height, and the dislocation and the others. So maybe thanks for the improvement of the antibiotics. So infection is not so frequent in Japan. But in all over the world, it is still controversial. If infection is getting down, decreasing or increasing. Some report is infection rate is decreasing due to the management of the wound or the control of antibiotics, the perioperative period. And in the same time, the frequent use of the antibiotics change the spectrum of the bacteria. So, for example, gram-negative bacteria is gradually increasing, and gram-positive is steadily or